Our name is New Direction. We come under the auspices. We come under the auspices of Change Go Live. Change Go Live is a nationwide organisation. We have 163 branches throughout England and Scotland. So our goal is to help service users regain control, change direction of their lives, and grow to be a person and have life and live life to its full potential. That's the ethos behind really what we do as an organisation. It doesn't vary, it doesn't matter what project you're in, that's what we're trying to work towards. Our values are is respect, empowerment and social justice, and I'm really sorry, it wasn't until we looked at this and we like, actually it doesn't make a whole load of sense, it looks a bit like Russian. But really, I mean, we do respect everyone that we work with. We work with them on a one-to-one basis. It's very person-centred. Well, our aim is to empower them so that they're making choices around their treatment. It's not our choice what happens to them, it's their choice what happens to them. And the social justice is that we get the best outcome for the individuals, but also for the community as well, which is very, very important. This is how to get in touch with us. If you all want to take a screenshot of that, it's absolutely fine, but you have got information as well. And it is correct, I can promise you. And we're going to start by something which we are really, really working with lots of partnership agencies around. Because of the increased numbers of drug-related deaths, we're looking at spreading naloxone absolutely borough-wide. Does anybody know anything about naloxone? Yeah. So it is a drug, and it temporarily, it's important to remember, it temporarily reverses the effects of opioids and prevents death following an opioid overdose. Now, Indra has brought along the kit. I'm just going to let Indra, do you want to take the lead on that, Indra? Yeah. Just so that you can see exactly what it looks like, and we can just show you how it would work effectively.
If you'd like to just have a look and pass it along, I'll demonstrate. It's basically an opiate antagonist in that it people overdose because they have respiratory failure. And when the opiate is taken, it's going to your brain, into the opiate receptors. There are different drug receptors in the brain, but the opiate receptors gets flooded with the opiate, and that depresses the respiratory center in the brain, and that causes people to stop breathing, and they go over or overdose, and that's exactly what happens. So what naloxone does is, as I said, it's an opiate antagonist. It just gets into your system, 3 to 5 minutes to work, kicks out literally the opiate from the opiate receptors, and you kind of like, it does it really quickly, and people will just sort of like, from being completely unconscious, just come up, catch a deep breath. That means the breathing system in the brain is sort of activated again, and you kind of like catch a breath.
So that's seen in Pulp Fiction.
Sorry?
That's seen in Pulp Fiction.
Oh, I've never seen Pulp Fiction. I don't know. Well, I guess it's
They're using adrenaline in that one.
Yeah. Yes, you can have the same reaction with adrenaline, just two completely drugs used for different purpose. Usually we ensure that most of our clients, we certainly offer it to everybody, whether they use opiates or not. Obviously, the clients cannot use it on themselves, but we encourage, part of harm reduction, we encourage people to not use drugs by themselves. And again, people may not be able to internalize what that means. It's like you're encouraging like drug parties and things like that. It can be interpreted like that. But no, it's actually harm reduction and safety, because they'll use anyway. So you can encourage them to use safely until they can actually come into treatment and stop their use or reduce their use. So this is what we're doing is saving lives, basically. We're not trying to be moralists and, you know, decide if people are going to use drugs or not. We just want to keep people safe because people are dying. So, so this is what not only do we hand them out, we monitor it. We offer training to not just the clients that come into the service, but to the hostels and different areas where clients are. And if you're in a particular area that you have lots of opiate users that you're aware of, we're always open to come in
ask and we'll
to train and things like that, because it really is a life-saving, is that simply. This is injectable. This isn't the only form. They now have the nasal ones. We just piloted like in Birmingham, areas like that, not too much in London, like in America and places like that, where it's like a puff, just puff it and you snip, well, for the person who's administering it, and it works really, really quickly, and it prevents people from having to fiddle about with this. Because if you like sort of imagine it's a crisis situation, someone's gone over, you're there, they're turning blue, some people panic and run away, unfortunately. You know, but it's important. You might know what to do, but you panic and you may not do it, may not properly. So when we're training people, we really encourage them to really look at this, understand how to do it. When they carry it, some people have it, oh, it's at home. You know, it's no good there. You know, to encourage people to walk with it. They worry about being stopped by the police, arrested, things like that. We encourage them to know it is not a illicit drug.
No, and it's not paraphernalia.
It's not paraphernalia. Even if the police do stop you and you carry this, you won't be arrested. It's difficult to encourage people who have fear of the police and had problems with criminal justice that it's okay to have this. So that's one of the challenges that we have. And to know that, well, you're not going to use it on yourself. If you're using with people, let them know that you have it, whether it's a drug den or in a home, or sometimes people go to other people's home and things like that. It's 1 milligram, 1 mil, and it's called a pre-filled syringe. Sometimes people say it's a pen. The trade name is Pronoxad, and there's always a batch number and expiry date number which we have to monitor. And that is to ensure that it's quite effective. So in a crisis, someone's gone over, it's not just to have it, but to know of the administration technique and what next to do. So I'm just gonna, the pen's going around, so I'm just gonna demonstrate. This is what we give to clients, and it's not opened until it's used. So you can see there's a red line along it. So when you're in a crisis, it gives you something to focus on. You know, it's like, what end do you turn? You know, where do you start? But there's a red line. You just grab the red line, off it goes, take the plastic covering off, and you twist, you know, and then comes the parts it comes in. It's the syringe, the barrel, usual, and 2 needles. Any idea why we might have 2 needles? Just in case. Well, hopefully there will be a kit for everybody. But you know, one might break, one will probably get lost. You know, generally, if you're providing a service where you injecting and things like that, it's generally two injectors, 2 needles that you'll have, just in case one get lost, or you need another one and things like that for the person. So it doesn't really have any specific significance except for that, just in case. So if you look at the barrel, it's marked in 5 sections. That indicates that all of this does not go into the client or the patient in one go. It's in divided doses for a reason. So when you're administering the plunger, it's down to the first line, then the second line and third line as need be. And the reason for that is whenever you administer this, you're actually causing the client to be in withdrawal. Because that's what you're doing. You're kicking out the opiate from the system. You're taking it out of the brain. It hasn't disappeared. It's still running around in the system. So it depends on the amount that they've taken or the strength of it. It will determine whether you need to use the plunger some more to go down. If you put that all in, goes into the brain, into the receptors, opiate gets kicked out, and it starts running around in the system, it comes with the circulation of your body, it gets back into the brain again, and you can go over again. So if you have a little more, you can give them a little more until you don't need to do that anymore, until they're actually, be quite alert. Obviously, as with any sort of intervention, medical intervention, or any sort of crisis or emergency situation, the minute that it's sort of recognized that that's what it is, an ambulance is called. I mean, of course, you encourage clients to do that. Some have reported they've called the ambulance and they've disappeared because they fear what might happen. They might be incriminated, things like that, which doesn't really happen, but so you encourage them to stay for the ambulance. So I'll just talk about this. So generally, this is what you have. Then the technique, injecting technique, it's into the muscle, usually in your deltoids, the best place, and just a lot. It can go through the clothing, so you can just go like mid-thigh, just along here, just bang it in and start to the first mark. That's sort of important. And this is what we teach people, and we get them to demonstrate and all of that. If you'd like to pass around, these are the guidelines. We give them these. So not only do we sort of like teach them, but we instruct them, and we give them that to take away as sort of like reminder for them, because it's not a one-time deal. They come into keyword sessions, we bring it, it's something that's always present, because people are dying, people, go over all the time, or sometimes, so once the kit is used, they come back to us and they get another one and things like that. The main thing following the administration of this is that people are put in a recovery position. It's an emergency situation, people might be turning blue, you focus on administering this, bang, bang, and then you put them in a recovery position. Because people might be slumped over like this, people go over in lots of different positions. They might be on their back. You see pictures of people in all sorts of positions. So that you want to get them into the recovery position. People familiar with the recovery position? Yes. Yeah, okay. Basic first aid, hands up there, get them over on the side, leg up, open the airway. That's the main thing, because it's a problem of breathing. People go over because the respiratory system in the brain is depressed. And this is a very important part of the service that we offer, because it's one of the first basic steps. You may not get everybody to come in to manage their drug problem or stop using drugs, but if we can save their life initially, then they might just come in and we can address that from them. It's just for opiates, which is heroin, codeine, dehydrocodeine, which you very seldom would overdose with codeine, because their tablets takes a while to get into the system, whereas heroin is quite quickly get into the system. Yeah, methadone, which is what we prescribe. So it's out there.
Okay, so that's a very, very quick overview. If you do want training, please let us know. Contact us, and if it's appropriate, obviously we'll come out and we'll deliver it to your service. It's not a problem. Okay, brilliant. Yeah. Okay. One of the other things that we offer, we do have a needle exchange service. The reason that we do this is that we are providing harm minimisation. Clean needles, there's less risk of the transmission of bloodborne viruses, BBVs, Hep B, Hep C, and HIV. We also have take-home sharp boxes, so people can dispose of their needles in a safe manner, and you won't. Hopefully, you haven't seen quite so many needles littering, playgrounds and so on, because we've been flooding it. It happens, I know, but it's better than it was. I don't think we'll ever eradicate it, because there are always irresponsible people, but it is better than it actually was. And we offer BBV testing. So bloodborne virus testing, I'm going to hand back over to Indra, and I believe she's going to do. Have we got time to do the BBVs, do you think?
We can demonstrate that if people want to have a
Are you
look at
interested
that.
in what a dry blood spot test actually looks like?
Probably can, because it's like 5 minutes, so yeah, we
Yeah.
can do that. Yeah. So yeah, Sherry, you mentioned needle exchange. Do people understand what that means? Yeah. So it's not just it's a series of instruments, equipment, swabs and stuff that we use. And this is just to, if people are not sure what we actually give out to people. Again, it's some people see it as a moral issue where we're encouraging people to use drugs, but again, it's back to safety. We can't emphasize that enough. It's preventing illnesses like bloodborne viruses and also getting people to improve on their injecting technique, preventing injury to injecting sites. So this is what a needle exchange pack looks like. That's what clients would be taking. And if you don't have any idea, that's what it is. It's syringes, barrels, cleaning, and of course a sin bin for the used equipment, which is very important. So they don't like chuck it away. We really encourage them to to use that and things like that. And if you have questions about what in there, you can sort of ask afterwards. So needle exchange is the forefront in the fight, not only to keep people well, but to prevent bloodborne viruses. We test for hepatitis and HIV. And hepatitis is hepatitis B and C, and of course HIV. Hepatitis B, if you know anything about hepatitis, HEPA is liver itis inflammation. There are lots of different ways you can get liver hepatitis. So this is about protecting your liver. You can get it from alcohol, you can get it from bacteria, it's not the only way, but this is the one we focus on with our service as it relates to most of our clients, and it's something we can do something about. And testing or screening, as with every aspect in life, you have breast screening, you have all sorts of screening. It's a part of health promotion, it's a part of empowering people. This is something that you can do at least, and a lot of our clients feel very helpless and hopeless when they come to us. So we present this to say, this is something that is the first start you're doing to protect yourself. Having information about your health and what you can do and things like that. So hepatitis, they're all virus, as it says, BBB, bloodborne viruses. So it's like hepatitis A, B, C. Hepatitis A is by an amoeba. It's all the various ones. They're all there on Dr. Google, but the ones we concentrate on, like this hepatitis B. Mainly in that we can, there's a vaccination for hepatitis B. It's 3 vaccinations plus a booster that we encourage people to take, and that prevents you for life from having hepatitis B. And because there is no specific treatment, doctors, liver specialists try different things, to manage it. You reduce viral load, but you don't always cure it. Some people can get rid of it, but it's not really what sort of happens. However, hepatitis C has always had treatment for it, even though there's no vaccinations, and not just treatment, it can be cured. It's one of the only illnesses in the last sort of century that we can actually cure, actually get rid of it, not just treat. So it's really important that we encourage people to get tested and then refer for treatment. Now previously there's a lot of talk about like high-risk groups and people who inject and all that sort of stuff, but research has found that a lot of people exposed to having hepatitis C for all sorts of reasons, not just people who inject. People can get it from straws, sharing and things like that, because sometimes sexual illnesses, but it's not a STD and such, because it's not because of the sexual activity, but because of the blood. That's what it is, a bloodborne virus, where we encourage people to get STD testing and things like that. That's not what it's about. So if there's any way that you have contact with people, so we encourage people to cover cuts and wounds like that, because it's just a little bit that you can't even see that can get into the system, and that can be passed on. Treatment, previously, I don't know if anyone ever heard about treatment or knows anyone. Previously it was interferon. It was like really horrible, lots of side effects. Took about 6 months. People had lots of side effects and didn't want to have it. But currently we have treatment that goes from 8 to like 12 weeks, various drugs that we use. Sometimes it goes from taking 1 tablet a day to 3 tablets a day. And what makes a difference is depend on the person's state of liver If you have cirrhosis or things like that, it might determine you need a longer treatment and things like that. So there's a whole process of referral and testing and blood test and liver test and things like that to see exactly where you are and what tablets or what medication is going to suit you. So that's hepatitis B. C, HIV. We don't treat HIV, but of course we liaise with the HIV clinic at King's and Lewisham Hospital, where we can refer people or support our clients who are going there, because again, part of what happens with people who use substances, they're not empowered. It's one of the things we teach them to do, and they don't always take care of themselves, and some people become very helpless and not want to attend to clinics and things like that. So part of the liaising and support that recovery workers do is really important, to get people to clinics and take their tablets and things like that, even though we don't treat them.
Thank you very much.
Yeah.
The clinical support that we offer for our clients in the borough, we've obviously covered the DBST, we've covered the vaccinations and access to the clinic. What we haven't looked at is the opiate substitution prescribing, OST, or medically assisted treatment, as it's commonly known as now. And that comes in two forms. We have an oral liquid, which is Viceptone or methadone previously, and we have buprenorphine, which can either come in tablets which are sublingual, or we now have little films which go on the tongue and dissolve almost instantaneously, and that's called Espronal. Both of these are prescribed to the client to not just help them stop using heroin, but it's also to encourage them to also cut down on some of the other activities that are associated with their drug use, which can be crime. It can be assault, it can be fraud, it can be all sorts of things, but that again is, it's empowering them to have a different way of life to the one that they've possibly had for quite a long time. Blood spot testing we talked about. We really wanted to show you how to do it. It takes such a short time. It's so important that we encourage as many people as possible to get tested, because if you get tested, you can get treated. If it's negative, great. If it's not, then basically you're going to enter into a form of treatment. Indra's really good at grabbing and jabbing. She'll be out there, she'll be pulling the people into the clinical room, and she'll be like, come on, get your £5 voucher. Doesn't sound a lot, but actually to our clients, it's quite significant. And it's also, we're taking part in Public Health England's study again this year. We did it last year, didn't we? And they'll get a voucher once they complete their treatment as well. I have offered my finger. So Indra's going to show you just how quick it is with my finger. So I hope you can all see, but it is just a prick on my finger that she's going to do. She'll show you how she does it. And it would take slightly longer because there are a number of circles that have to be filled up on the card. Afterwards, please come up and have a look. But it's really easy, really simple. And I say it doesn't hurt that much, actually. It stings. It does sting, but tell them it doesn't hurt, don't you?
If you say to a client to get tested, they would imagine all sorts, and make something a 5-minute test can be quite problematic. So there's a lot of reassuring and explaining and having people consent for this and determine their capacity, whether or not they understand what we're doing, they understand the consequences of the results, and what can really happen isn't just test and go away and then we catch up with you and say, oh, by the way, you're positive and this what sort of happens. We anticipate that people will have concerns and we discuss it with them, reassure them and things like that. Unfortunately, some people after testing will engage in risk behavior again, so some people would need to be retested. So it's an ongoing process. Sometimes it's not just a done deal. You test once and you go. It's really ongoing. As with every lab test, there's a lab form to be filled out, and we have the client's consent, which is really important. Labs won't sort of test without the consent. There's tracking, just to make sure we haven't sort of mixed up the forms and things like that. This is the specimen card, and it's where we put the blood in. This we handle with gloves because it's a specialist card that will determine the results. So the client, the ID, and we fill the circles with blood, barcode to the back, and the bag for the specimen and also the documents in the back. Put that in the carrier bag and send it off to the lab. And of course, to landslide swabs, tissue, and things like that. Of course, we pre-assess clients, make sure that they don't have any bleeding disorders, because it might be a simple prick. They can still, a lot of our clients are on like blood thinners due to blood clots and things like that, so we pay attention to that. It won't necessarily rule them out. Again, it's not the end result, but the decision making, whether or not you considered whether or not somebody would be at risk and things like that. Any questions about the testing? So, yes, Sherry, come closer. So I've reassured her, and I've determined that she has capacity, and I would sign her off, and I would have everything prepared. I'd have my little bin, that, swabs. I didn't bring a bin, so I'll borrow one from the pack. Where is the pack? Yeah. Someone mind just bringing that up for me, please? Yeah.
I'm right-handed, so she's going to use my left hand.
Just some basic things about blood taking. Obviously we want clean hands, and sometimes it's discreetly sort of say, make sure that they haven't been just come from fixing the car or doing whatever. We have lots of landscape gardeners and in a rush to come in. If they haven't, make sure they wash their hands, and sometimes washing hands, the warmth helps them to give you a nice flow, so things like that. Wrong end. Yeah. That's it. Put my gloves on, which I don't have. Forgot my gloves. Okay. I look for a nice fat finger.
Good.
Usually and it's okay to use the word. Yeah. It's okay. On the sides, usually in the front it's quite sensitive. It's more sensitive than the side, so we'll inject on the side.
Now I get them to look away as well.
Sometimes I said, you like me to have someone to hold your hand? Whatever it takes. You just want to stick, there comes the blood.
I bleed well.
So, this is what I do all day long. Well, not all day long.
This is how quick it is, seriously.
And this is HIV as well.
It's the one card for all the tests.
Yeah, it's just.
So Sherry, I don't have my gloves, so you just press on
That's it.
Do you get a lollipop?
I want my voucher.
Well, we partnership with Public Health England, the survey that they do yearly. It's for the government, so we encourage the clients to participate in that test to help the government determine how many people how many people have diagnosed with Hep C. It's all about risk and injecting behavior. So that helps Public Health England to, to have all the figures and things like that. And of course we give them a £5 voucher. The test that they do for Public Health England is not diagnostic. We won't get the results. Public Health England gets the results as to who exactly is infected. What we get is a report at the end of the year about how many people who is infected, just for statistics and for their statistics. It doesn't help our clients, and they understand that. So of course, if they don't know their results. They fill out a questionnaire, and we do like 2 parts. One that's diagnostic, and one that goes off as part of the survey. So we just let it dry, put it in the pack, and just sort of send it off. Yeah. So that's in effect what, and it's called blood spot testing, blood spot, dried blood, because it's as opposed to wet blood, which is venous blood, which you get from here. Which we probably would refer people on if they're positive and would need treatment, as it needs venous blood to get to determine viral load and DNAs and things like that in certain amounts of treatment. Yeah.
These are also another box, so it will show you some of the drugs that will come up in a minute. If you can just sort of pass them around.
So this is just to give you an overview of what you know might look like.
So we also have a family and carer support service, because we recognise that drugs just don't affect the individual that's taking the drugs or the person that's drinking the alcohol. It's like a ripple effect. You have the user or the client, and then you have all the people that surround them. So we have a dedicated family and carer service in the building. Saturdays are the day identified for any family and carer, and anybody that can go to it, as long as they've got a loved one actually in the service. It doesn't matter if they're out of barrel themselves, but they can still come along to us. Right, we're supposed to have a little break here, but obviously we're not going to have a little break because we started this a bit late. How do you define a drug? Does anybody want to hazard a guess at defining a drug?
Something that affects the brain and function.
So the official definitions look a bit like this. So the World Health Organization say a drug is any substance which, when taken into a living organism, modifies the use of its functions. It's quite simple, really. The Drug Education Forum says drugs is a substance people take to change the way they feel, think, or behave. It encompasses prescribed medication, people forget that often as well, over-the-counter medication, legal drugs such as alcohol, tobacco, volatile substances, and illegal drugs covered by the Misuse of Drugs Act 1971. Additional information you can find at this website, so it is quite useful if you haven't got a really good understanding of drugs. Nip yourself on there, and it gives you much, quite good coverage. So what is a drug, and how do we use it? Normally we look at this model, which is called drug set and setting. It's quite clear there. It's nicely explained that the drug is substance which the frequency and the amount and how it's used will affect how you feel. The set is the person's psychology, can't say that. Their state of being, where they are, what type of culture they've got, history they have, where their background, and the setting is where they use with whom, and what stress levels that they're at can contribute to the amount that they're actually taking of the drug, and it goes around.
Yeah, it's just really helps you to understand the complexity of substance misuse. It's not simply about using the drug. It's about your psychology as well, your mental health. Sometimes you may be predisposed, or sometimes you may develop mental health concerns as a result of using the drug. And of course, the sort of social consequences, where you use the setting, the quality of your support team in terms of your recovery, and the interpretation of use, because some people might say, yes, I use the drugs, no problem putting their hand up, but might say, I don't have a problem, don't know what you want to talk about, I can leave it or take it, blah, 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 etc., etc. So it's all of these mix it. That's a really complex issue, but it's important to have an understanding of the definition of all three sets.
Interestingly, the drug that people most tend to be ambiguous about is alcohol. Interesting. Okay. So we talked a little bit about that, so let's just going to go over, I don't know why they've done it twice, but they have. Drug set and setting.
Just more information,
Yeah.
yeah.
And the classifications. Do you know what classifications we have around what the categories that drugs fall under? Does anybody know what they fall under?
A, B, and C.
So we have depressants, we have stimulants, and we have hallucinogens. Okay? So what's a depressant? So it sedates the central nervous system, and the effects can include decreased brain activity and heart rate, which is like our little speedometer over there. Relaxation and sleep induction, anxiety reduction, lowered inhibitions, high doses can cause unconsciousness and coma, physical and psychological dependence. Do you want to name a few? Does anyone want to name a few depressants? Anyone want to have a hazard a guess?
Alcohol.
Alcohol, yeah. Heroin. Yeah. Codeine.
Xanax.
Xanax. Don't see so much Xanax here, but we do see it, and there's quite a lot in Greenwich, funny enough.
There's one particular drug which can be both a depressant and a stimulant,
Yeah.
and that's alcohol.
That's
Because
alcohol.
initially, that's what it does. It can stimulate, make you excited. That's why people love it.
Yes.
And then, of course, over the years of use it, it can become a depressant, and people actually do get depressed over excessive alcohol use and etc. Yeah. And Prozac is an antidepressant. It helps reverse the signs of depression.
So stimulants, obviously completely opposite, so it stimulates the central nervous system, so we've gone from being slow to being really quick. It's increased feeling of energy and alertness, increased brain activity and heart rate, increased doses can cause anxiety, panic and paranoia, possible temporary psychosis, psychological dependence, and a really well-known stimulant, obviously, is cocaine. It's very cheap now, very, very, very cheap to purchase. And there's quite a significant increase in the use of very young people using cocaine, as opposed to crack cocaine, which used to be the one that we saw more of. But yeah, so that's the most well-known stimulant. And then we have hallucinogens. We couldn't find a speedometer that would like be blurred, so we got that little image there. So
which is pretty much what
Well, it looks like.
does. It
It's like a
gives you
1990s or
yeah,
Oh,
yeah.
it distorts the biochemical signals to the central nervous system, is effectively what it does. And hallucinogen can include cannabis, it can include MDMA, and it can also, yeah, alcohol, because you get DTs from that. Yeah. So distortion of senses, altered perception of time, sound and space, heightened self-awareness, mood exaggeration. You see these people that are like really up here or really down there, you know? Causes anxiety and panic, and we have quite a lot of that in presentation, particularly with our mental health clients, our dual diagnosis clients particularly. Other categories of drug use. We wanted to talk to you a little bit about how people tend to sort of start using their drugs. So most people don't go into it like, yeah, I'm going to use drugs. I'm going to use it. I'm going to get myself on a script. That's not the idea that they tend to go into it. It tends to be experimental. And it is almost a rite of passage that there will be young people that will experiment with a mind-altering substance, whatever that looks like. Whether it looks like alcohol, whether it looks like cannabis, whether it looks like pills, it's quite normal. We might not like it, we might not approve of it, but it is actually quite normal, and there's a huge amount of peer pressure that encourages them to try something. Yeah? Experimental is trying a drug for the first few times. It can happen at any age. I mean, we have people
have
that come
started in their 30s.
in their 30s and 40s that have had an experiment and thought, oh, I quite like this, you know, and then it's led to more serious problems as they've become more dependent on using it. But it is generally young people that start at the experimental age. They may not know what to expect from that experience. They might be completely naive, or they may have friends that are encouraging them to do it. But they haven't got an expectation about what it will feel like for them. They may not know how to take the drug or how much of the drug to take, so it can be quite dangerous because of that particular reason. And they may be well informed, but they're still curious about using that particular drug. And again, as specified, it is very often alcohol. That's what they would tend to start with. I'm not even going to ask you how many people go home and having a drink. It then kind of moves on to being recreational. Recreational drug use, it may be occasional or it may be regular. We have people that use heroin once a week. It's recreational to them. They're not heroin dependent, and they can manage to keep it at that level. Not everybody can. We have people that go out on a Friday night, they'll have a few lines of cocaine with their alcohol because they think that's a really good idea, and then once they've had it, they have a few more because it's an even better idea. It's still recreational. They're doing it on Friday night. They're only doing it on Friday night. It's not as problematical as it can become when it's Friday becomes Saturday, Sunday, Monday. But we do have the recreational user. We don't tend to have a huge number of those in our service because we're complex needs, but we do still cater for them. It's associated with socialising, dancing, listening, playing to music, watching sports and films. Again,
Fun times.
yeah. It becomes a problem where they start to binge, where they're using a lot of drug or more than one drug in any session, because polydrug use increases the danger to the client. Polydrug use, I mean, they might use alcohol, which is a depressant, they might use a stimulant. Using alcohol and cocaine creates another drug called cocaethanol, and that has serious implications to the heart. It can cause a heart attack. And not many people actually realise it's the only two drugs that the body will metamorphosize into one, but it will.
And this is when the people who use stimulants like cocaine present in hospitals, clutching at their chest, thinking they have a heart attack, and then they get referred to us afterwards. And a lot of times, because they're not like what's known as dependent or use it a lot, occasional, it can still happen, you know, and that's what makes it so dangerous, because I'm not a drug addict, you know, so it can be something that's episodic. So we encourage people, and they think, well, it's past, I'm going to reduce my use, but they still don't get it. That's the two drugs actually forms a third drug, and that's the consequences of it. There's a lot of teaching involved, especially with binge drinking, because you're not dependent. I don't have a problem. And that's what makes it so dangerous as compared to if you're dependent and you kind of you have problems. So shall we go into
Okay, so one-off occurrence can occur alongside recreational use. We kind of get involved when it becomes dependent. So it does develop over time. It can be as short as 6 weeks for heroin dependence. It can be if they're using every day. It's a strong compulsion to keep taking it, both physical and psychologically. With heroin, it is a very physical dependence. They will feel very unwell. It won't kill them if they stop. They will feel very unwell, though. They will feel like they've been hit by a bus when they stop using. And withdrawals kind of feels like a really severe form of flu to start with, and it just progresses, and you lose control of your body functions. It's a very unpleasant feeling. So clients who are dependent on their heroin use do not like going into withdrawals. It happens often every day. They will be using the substance every day. Again, includes alcohol. We had, was it yesterday in the morning brief? Were you there yesterday? We had a client who's currently in hospital who had, over the course of 3 days, drunk 17 litres of vodka.
Oh.
17 litres of vodka. This particular client, bless him, his wife's recently died. There is a reason why he's drinking himself. His wife died just before Christmas. But it's such a shame, 17 litres.
How did you get into the shop?
Well, do you know what? It's so easy. You've got Tesco's that deliver.
Of course, yeah.
You don't have to go out anyway. You've got an account with Tesco. I've got an account with Tesco. I've got an account with Sainsbury's. I can get it delivered from 2 different people. Boom, it's at my door. Don't even have to walk anywhere. So easy. So easy. We don't. All you have to do is let the man in with the crate. Because you're dependent on it, the dose that you have is not enough. So you increase your dose. You may do it incrementally, or you might not. You might one day have 1 bag of heroin and the next day, do you know what, I'll have 2. Increase your risk of overdose, why don't you? 2 bags of heroin, your body isn't used to it, and that's when our clients go over. It can involve physical and psychological factors, so say heroin particularly. Cocaine is out of the system normally within 3 days. Normally within 3 days. You haven't got that high, it's hours that the actual high is lasting, but it will still be in your system for 3 days.